have resonance with this group. And I'd now like to hand over to Carolina to introduce the next speaker.
First of all, I would like to thank the WTO, especially Professor Quigley and the Rome Foundation for inviting me to be part of the organizing committee. And I would like to introduce next lecturer, Dr. Gwee. Dr. Gwee is Associate Professor of Medicine at the National University of Singapore. He is the lead author of the Asian Consensus on the Irritable Bowel Syndrome and has also contributed to the World Gastroenterology Organization's IBS guideline. He is currently the president of the Asian Neurogastroenterology and Motility Association. He will talk about interpretation and reporting of GI symptoms, differential diagnosis, and diagnostic workup in Asia. Dr. Gwee.
Thank you. Good morning, ladies and gentlemen. Let me just try to figure out. Okay, hi. Okay. I just want to first tell you about roughly the prevalence of IBS from the part of the world I come from. So, looking roughly from, broadly from Japan down to Korea, China, Hong Kong, and Singapore, you can see that using the Rome 2 criteria, our prevalence range from 5 to 10%. The studies from India are a little bit more limited in the sense that the Rome criteria wasn't applied, but the numbers we've got are shown there, somewhere between 7 to 4%. And then there was a study from Pakistan reporting a prevalence of 13%. Now this was the world view of IBS before the new millennium, applying mostly the old Rome criteria as well as the Manning criteria. And the two areas that stand out will be in the US and in the UK, where high prevalence of about 20% were reported. Whereas in the old times, the prevalence reported from Asia, particularly from Thailand and Singapore, was a very, very low level of less than 5%. So this raised some questions about whether we are missing the diagnosis of IBS in our part of the world, or whether it was just simply that it didn't exist as much as it used to in the West, or it still does in the West. I want to use the next few minutes to speculate on the possible reasons for this discrepancy. In these four aspects. Number one, that gastroenterologists, at least from Asia, tend to focus on organic diseases. We've got lots of Helicobacter pylori infection, gastric cancer, gastric ulcers. We've got lots of hepatitis B infection, hepatitis B-related cirrhosis, and hepatoma. So most gastroenterologists will be in good business just seeing those two without having to waste time talking to patients with functional GI disorders. And I think the other aspect I want to bring up in my talk is that our patients tend to present with what appears to be more dyspeptic presentation if we go by Western criteria and standards, because there's a strong association with meals, and that many of our patients present with upper abdominal localization of their symptoms. And then I'll just highlight some differences in the way our patients may look at bowel habits, and then finally tell you about some of the differences in healthcare practices in our part of the world. So firstly, gastroenterologists. I've actually brought this up to ARMY when we first did our planning, that the fact that we call ourselves gastro first rather than enterologists first has already directed our thinking from the time we started our training to think about the stomach as the origin of many of our symptoms, or at least the beginning of our journey into the gastrointestinal tract rather than a bottom-up approach. So I'll just quickly show you that in our part of the world, many doctors tend to misattribute IBS symptoms to gastritis, gastroenteritis, and gastroesophageal reflux. A study from Hong Kong showed that when they looked at subjects with IBS criteria who had consulted their doctors, the doctor's diagnosis was IBS in only 21%, and the doctors made a diagnosis of gastroenteritis in 64% of these patients. In a study from Taiwan of subjects undergoing healthcare, 481 patients were initially suspected to have typical dyspepsia, but on closer examination of their symptoms, it turned out that almost half of them actually had IBS criteria by the Rome 2 criteria. And then an interesting snippet from this study was that 21% of these patients with FD criteria who had consulted their physicians had undergone a hysterectomy, whereas only 7% of non-consultants with FD criteria had to undergo a hysterectomy. In a study from Singapore of primary care patients referred for an open access upper GI endoscopy with the view that these patients were likely to be suffering from GERD or acid reflux, and with a view to starting PPI treatment after the endoscopy, we found that 25% had just IBS. Next, I want to dwell on some of the possible social cultural aspects that may have led many of our patients as well as their physicians to focus their mind on the stomach rather than the bowels, even though all these patients had criteria for IBS, even by the Rome criteria. And one of the things that we've always felt is that in China, we tend to place a high value on the pleasures of eating. So a study from South China of a big gastroenterology clinic looking at large numbers of patients with various subsets of functional GI disorders, functional dyspepsia, IBS overlap, and IBS, found that postprandial fullness was the only independent risk factor for the FD IBS overlap versus the FD alone. And they also found that fullness, bloating, or distension was not distinguishable between IBS alone and those with IBS and FD overlap. I want to say a bit more about this possible dyspepsia IBS ambiguity and how it may arise. In a comparison I did of patients from India and patients from England, we've observed that among patients from India, 46% of these patients with IBS criteria presented with upper abdominal localization of their pain or discomfort, whereas in the English patient population, 96% presented with lower abdominal pain. And bloating, when we looked across the various parts of Asia, we found that it was as common as abdominal pain, particularly in South Asian studies from India and Bangladesh. And then when we compared the prevalence of bloating between community series and patient series, we found that when we moved from the community to the patient setting, there was an even greater proportion with bloating in the patient series. And now a little bit about bowel habits and how we may perceive differently what is constipation, what's considered to be a hard stool or a soft stool. This is a study that's going to come out soon. It's a study from Seoul in Korea where they looked at a large group of patients with irritable bowel and assessed their bowel habit using two forms. Down on the column here, we've got the definition or the subcategorization of IBS based on text descriptors of their bowel habit. And across here, we've got the definition of their IBS subtypes based on the stool form, the Bristol stool form. That means they showed them pictures and asked them what kind of stools they had. It's a bit too much to look at all the numbers and trying to make sense of it, and it's probably not intended as part of the study. But if you looked at just the CIBS category, at least based on the Bristol stool form, they reported a total of 37 patients qualifying in this group. Whereas by text descriptors, there was only 27 qualifying as CIBS. And then if we looked at the unclassifiable IBS, it was 8 by text descriptors. And then it was 76, it jumped to 76 when you use the Bristol stool form. I'll just speculate on some of the possible reasons for this discrepancy. What we did was when we met together among the Asians and discussed this study, we realized that many of our IBS patients tended to classify type 3 as hard stools, whereas I think if we look carefully in the Rome iteration, they generally define hard stools as type 1 and 2. So where does that leave the patients who say they have a hard stool when they have the IBS and the hard stool is only a type 3 rather than a type 2 and 1? So I think that might leave them as unclassifiable. So then we then got together and developed what I call an Asian IBS consensus. Skip the details here. This is the algorithm that we put up. It will be in your handouts. But just to highlight to you that we wanted to bring to the forefront bloating as a key symptom. We felt that we only needed one bowel symptom characteristic to get a person recognized as a possible IBS. And for IBS-C constipation, we considered types 1 and 2 Bristol stool scale as constipated stools, and we considered types 5 and 7 stools as IBS, as diarrhea type stools. And lastly, I want to question the relevance of the illness behavior model for at least some of our Asian communities, whether this is applicable, because I want to show you that there's a very high level of consultation behavior among our Asian societies, and that we have differences in healthcare structure that may make the assumptions invalid. So in Singapore, we noted that 84% of our patients had consulted for IBS. In Japan, 59%. In Hong Kong and Taiwan, 57 to 55%. And the primary care setup across Asia is extremely different and vast and varied. In India, they start off with paramedical team in a health center out in the public. In China, patients go directly to specialists in a hospital. In Thailand, patients go to generalists who are based in hospitals. In Taiwan and Korea, the specialists are out there in the community and patients go directly to the specialists. So now that I'm running out of time and the light is flashing, I just want to bring up to you that maybe we look at doctors and patients differently in Asia. Maybe the patients see doctors not necessarily as people who give pills and undergo tests, but even as personal coaches and life coaches, so to speak, in the Western parlance. So I hope that with this brief presentation, I've been able to give you all a feel for how differences may be driving some of the different perspectives of IBS in Asia, and that this will help to open our minds to looking at IBS beyond the arbitrary guidelines that we sometimes impose on ourselves. Thank you very much.